Hi, this is Dr. A with Intro to U.S. Healthcare. We are covering Chapter 6 of Niles' Basics of the U.S. Healthcare System, and we are looking at inpatient services, and this is Part 2. Okay, so let's look at hospital types by specialty. A general hospital provides many different services to meet the general needs of its population. Most hospitals are general hospitals, meaning you can go there to get surgery, you can go there to get medical care, to have intensive care units, there's cancer treatments, all the things, it's all there, many services. Now you also have specialty hospitals, so they provide services either for a specific disease or for a target population. So an example are psychiatric hospitals, children's hospitals, women's hospitals, cardiac hospitals, cancer hospitals, rehabilitation hospitals, and orthopedic hospitals. So again, either a specific disease or a specific population. So psychiatric, specific disease, cancer, specific disease, children's or women's targeted population. So in our area, for example, we have Arkansas Children's Hospital. So that one is a targeted population. St. Jude's Children's Research Hospital. So this one is a targeted population and a specific disease. So it's cancer in children. So this one kind of is double specialty, if you will. And another one is, for example, the MD Anderson Cancer Center. So that is one that is targeted to a specific disease, to cancer. So hospitals can also be classified as single units or multi-unit operations, although I must say with the need to stay financially afloat, a lot of hospitals have gone into multi-unit operations. If there are two or more hospitals that are owned by a central corporation, then that's an example of a multi-unit operations. So multi-unit hospitals are the result of merging or acquiring other hospitals that have financial problems. Usually there's larger entity hospitals, and they may be grabbing up some of the smaller community hospitals and expanding into a multi-unit operation. They can be operated as for-profit or non-profit or even government-owned. These hospitals often form systems because it was more cost efficient. So some of the example of things that are then offloaded to the more central owning unit are things like human resources, IT, and things like that. They're all like centralized, so you don't have to have that department duplicated in all the smaller locations. And so there's a lot, so it cuts to some of the overhead costs and makes it more cost efficient. And so, again, because of the financial reality of the world that we are in currently, the bulk of your hospitals are in a multi-unit operation of some sort. We'll talk about this later in the legal aspects, but you have to be careful also. Some of these mergers have to be submitted to the FTC because you cannot have monopolies in regions. So, hospitals might be barred from buying too many of these little satellite units or becoming too big in the area where choices are taken away from the consumers. A health network, though, is a group of hospitals, physicians, insurers, and other providers that work together to provide services to a community. And so they may still be kind of like independent entities, but they work together. And so they would say, like, for this hospital or this group of physician there are preferred providers, even though that group of physician, their clinics may not bear the same name as the hospital, for example. In 2017, there were 3,494 community hospitals that were in a system and 1,794 hospitals that were in a network. So it is, again, a growing trend for financial stability and many other reasons. So other ways to classify hospitals. They can be classified by length of stay. A short stay or acute care hospital focuses on patients who stay an average of less than 30 days. Community hospitals, voluntary hospitals are short-term. More than 90% of the hospitals in the U.S., or probably everywhere, are going to be these acute short-term hospitals. You're not meant to stay a long time in a hospital. But there are some long-term care hospitals. They focus on patients who stay an average of more than 30 days, and this could be 6 months or more. They usually are rehabilitation hospitals or chronic disease hospitals. There are some ones where if a patient has to be on a ventilator long term, they will go to a long-term care hospital. They can also be classified by geographic location, so they are either rural or urban. In 2017, there were 1,875 rural community hospitals, and there were 3,387 urban hospitals. So my husband works at a rural hospital, and they do tend to see more poor and elderly patients, and they can have more financial issues. And so some of them have gotten creative. Like one of the things that his hospital has done to stay afloat is, one, they're part of a multi-unit system, so there's that. Two is they do not have an ICU anymore, so they got rid of that, and they converted some of the space in the hospital to have a psychiatry unit, so an adult psych unit, and that has been really good for them to keep them financially afloat. They have also done this thing that we're going to talk about. Due to financial issues of rural hospitals, the Medicare Rural Hospital Flexibility Program was created as part of the Balanced Budget Act of 1997. This allows some rural hospitals to be classified as a critical access hospital. And so his hospital went through the process of being classified as a critical access hospital. They have to have no more than 25 acute care beds. They have to be at least 35 miles away from another hospital, and they also have to provide emergency care. So his hospital meets all of these requirements. They have an emergency room, and you would ask, well, what do they do if they get a critical patient? Since they don't have an ICU, what they do is they transfer it to the patient to their sister facility, the larger hospital that are part of their units, or wherever the patient may want to go. So their ER just stabilizes the patient and then ships them off to get critical care. But it still gives access to emergency care to the consumers, to the patients in that area, in a small area. So this classification then enables them to receive additional Medicare reimbursement. It's called Cost Plus, and that allows for capital costs, which enables these facilities then to expand, or at least to stay alive. And so this has helped his hospital quite well. We also have teaching hospitals. These are hospitals that have one or more graduate resident programs that are approved by the AMA. So doctors that have just recently graduated from med school can go do their residency there. And academic medical centers are hospitals that are organized around a medical school. And so students may do their clinical practicums there where they haven't graduated yet. They're doing their clinical hands-on experience there, and they're associated with the medical school. And it can be a medical school, but it can also be, there are some that have nursing programs and other allied health programs. There are approximately 400 teaching hospitals that are members of the Council of Teaching Hospitals and Health Systems in the United States and Canada. We can also classify hospitals as safety net hospitals. So these hospitals provide more charitable care than other hospitals. They receive more payments from the CMS because they provide more uncompensated care. And so one of the hospitals in our area does that. So if you get a medical bill from them for care and you cannot pay it, because you just don't have the money, because you don't make enough money, right? So you can apply to have that care be uncompensated care, so the bill be taken care of, but you have to prove, of course, your financial need. And so there's a little process to go through, but if you can prove that you have financial need, they just write off the bill and you do not have to pay for that medical care. It becomes charitable care. Church-related hospitals were also developed as a way to perform spiritual work, and so there are hospitals that are associated with various faiths. In our area, we have some that are Catholic, some that are Baptist, some that are Methodist. And the Catholics were the first ones to establish hospitals. These hospitals are often community general hospitals. They can be affiliated with the medical schools. Ours is. But what you'll see is in the one that we have as Catholic, there are a few nuns that are walking around, talking to patients. Some of them even work as nurses. They'll have maybe prayer time. They'll have a chapel on site, etc. Osteopathic hospitals focus on holistic and preventive approaches to care. Their emphasis is on diet and environmental factors on top of just the regular care. So we have to talk a little bit about hospital governance. Hospitals are governed by a chief executive officer, a CEO, also by a board of trustees or a board of directors, and the chief of medical staff. So the chief of medical staff has got to be a doctor, an MD, somebody that knows all the medical things. The CEO is more of like a business person, right? It knows how to run the hospital. So the board of trustees or the board of directors is legally responsible for the hospital's operations. It can approve strategic plans and budgets. It has the authority for appointing, evaluating, and even terminating the CEO. So if the CEO is not doing a good job, there are problems going on, the board of trustees can just fire them and hire somebody else to run the hospitals. The boards are often have subcommittees, including quality and finance committees, to keep track of everything that is going on in the hospital. State governments oversee the licensure of healthcare facilities, including hospitals. So they usually inspect their hospitals yearly to make sure they're still operating the way they're supposed to and to validate their license. States set their own standards. It is important to know that all facilities must be licensed, so you cannot operate a healthcare facility without a state license, but they do not all have to be accredited. However, the accreditation certifications of hospitals enables them to obtain Medicare and Medicaid reimbursement, which is something that NMAP wants. But like, let's say if you had a like plastic surgery, small hospitals that was privately owned, that was for profit, and they did not deal with Medicare or Medicaid in any way, shape, or form, all they would have to do is be licensed by the state to operate. They would not need to be certified because they're not dealing with Medicare or Medicaid. So hospitals are also licensed to operate within a certain number of beds. So if they wanted to expand, they would have to update their hospital license. So let's talk a little bit on the current status of hospitals. So quality improvement processes. The Institute of Medicine's definition of quality in healthcare looks at 6 dimensions. So we need to look at safety, patient-centeredness, meaning it's about taking care of the patients, efficiency, so doing things in a timely manner, efficient without too much waste, right? Not wasting time, but especially not wasting money, so not ordering unnecessary tests and procedures. Effectiveness, meaning what is done works and makes the patient better. Equity, meaning that all people are able to have access, which means you have programs in place for those who may not be able to have the means to access the care. And this little graphic is a graph that represents equity, where some people may need more help to access the care than other people, right? And then timeliness, so it's kind of tied to efficiency, but meaning that things can be resolved and taken care of in a timely fashion. You don't have extended delays for procedures where it can take months and months and months to get on the schedule. And so let's continue looking at different things that can help with the quality improvement process. So one program is called Lean Six Sigma. It was initially a Motorola approach. It uses statistics to identify and then eliminate defects in defects. So for them, it was in the assembly line. For the hospitals, we use the Lean Six Sigma to identify and eliminate defects in patient care. This is data-driven decision-making, trying to reduce variations in processes and promote efficient use of resources. And so you have to use a lot of big data and statistics to run Lean Six Sigma, and people in the hospital can be trained to do that, to look at quality processes within the hospital. There's also the Plan, Do, Study Act. This was developed by the Institute for Healthcare Improvements. It's a 4-step cycle that focuses on improvement of workflow. And so this is easy to implement even in a small department. The way you look at it, you look at a problem or something that could be done better. And so you plan your improvements, then you put your improvement in place. You study the outcomes. So you have to have data from before and data for after. Usually you first do like a pilot program first, so you can do it on a smaller scale, test it out, see if it works. If the solution has the intended outcome, it works, then you can act and put it out. So maybe if it's a pilot study is done in like one little department in the hospital, we find that it works, then it can be implemented in all the departments to which it applies and hospital-wide. So it's, again, a way to eliminate unnecessary steps in workflow and to improve workflow for patient safety, but also for efficiency of care. Large hospitals are working with the Joint Commission Center for Transforming Healthcare to implement processes that target safe and quality patient care. For example, the BDSA can be used to reduce medication errors by analyzing the process of providing medications, determining what changes need to be made, assessing if the changes that were made were successful by looking at a reduction in medical errors. So if you think the problem is X and you have your medication error rates before you put that solution in place, and then your medication errors do not change, that wasn't the problem. You have to do something else. But if your medication errors drop, then that was a proper solution, or at least it helped improve part of the process. Lastly, we'll talk about the Leapfrog group. I remember when this got started, they initiated an annual hospital survey. It was endorsed by the National Quality Forum, and it was to assess hospital safety performance standards to reduce preventable medical mistakes. In June 2012, the Leapfrog group then also initiated the Hospital Safety Score, which is a letter grade rating of how well hospitals protect patients from accidents, infections, injuries, and errors. Data are collected from the Leapfrog hospital surveys, from CMS, and from AHA, and they bring it all together and calculate a letter grade safety rating. And so I remember these were put out a few months ago for local hospitals, and some of them were A+, and then there was one that was like a D, and it was like a big thing in the news about like what was going on and how did they get that letter grade, etc. So it's something you can look up for the hospitals in your area, so you can see how good they are at promoting patient safety. It's also good to know like kind of what all goes into calculating that. So anyway, so this is the end of the inpatient. You have one more lesson coming up on your outpatient services.